we get this pulled up, I will say I don't have a disclosure slide as many of you all did. I'm one of people, so it doesn't really matter. So what we're going to be talking about, sorry, that was all in space. So we're going to be talking about a crashing patient, more specifically the patient with the massive pulmonary embolism. And before we get started, a lot of the things that I talked about will be very similar to the prior lecture because it's essentially the same pathology except with a mechanical obstruction. So in emergency medicine, we see sometimes 20, 30, 40 patients a shift, and we get into this almost protocolized type of mentality. You see chest pain, you do this, this, and this. You see resuscitation, you do this, this, and this. And I want to start by saying that that when a patient comes in, we should always give them the time to actually think about what's going on, think about the pathology. So I want you guys to take a look at this patient, for example. Let's say this is a 50, 60-year-old patient presenting with shortness of breath. They're tachycardic, they're hypotensive, they're tachypnic, oxygen saturations are normal. And you look at him, and like we talked about in the other lecture, is what is our initial reaction? And in most cases, it'd be the right thing to do, but how many of y'all would give like a liter of fluid, maybe 2 liters, reassess, get some blood cultures? And again, like I said, like in most cases, that's the right thing to do. But I challenge all of you to think about the patient again and use your tools around you, right? Either it's an ultrasound machine or history, physical exam. We've gotten so taken away, and I'm kind of one of the proponents of you don't necessarily have to do a physical exam in all situations, which is not the right thing to do. But look at the patient, right? Are they perfusing properly? Are their extremities cold? Take a good history from the patient if you can, or from collateral family. And then do an ultrasound, right? Take a look at their belly. Is there blood in the belly? Is there fluid around the heart? Is the heart contracting appropriately? Is there beelines? You know, like you can get a lot of information by using that machine that's right next to every single resuscitation. Now, for this patient, we already know the pathology, right? We know what's going on. It's a massive pulmonary embolism. And before we dive into the management of it, I want to talk a little bit about the physiology. Like Dr. Cade said earlier, if you know what's going on, you don't have to necessarily memorize things because we forget things very frequently. So if we understand it, then we know what we need to do. So what happens when that big clot hits? It jumps off the DVT that you already have, goes through, and lodges in the pulmonary artery. Well, immediately you get this huge release of cytokines. Your pulmonary vasculature clamps down, and you get RV failure. And that RV failure leads to a couple other things, which is decreased cardiac output from the RV as well as from the left ventricle, and ischemia. So we're going to talk about each one of these things. So let's talk about the right ventricle, or the RV failure. So the clot hits, you get dilation of the RV. And remember, in pulmonary hypertension, oftentimes the RV has had time to compensate. The musculature is a little bit bigger. But when the PE hits, this is an immediate increase in pulmonary vascular resistance. So it dilates. And unlike the RV, unlike the left ventricle, the right ventricle does not compensate very well, right? We've seen the patients in our emergency departments that have blood pressures systolic blood pressures of 200, 250, sometimes even 270, right? And we're like debating what should we do for this patient, right? The left ventricle can compensate very well. But what happens to the right ventricle is it decompensates very quickly. It has a very low threshold to be able to compensate. So you get RV failure very, very quickly, which is a problem. All right, so the next thing that we're going to be talking about is decreased cardiac output. Now, both of these systems you can kind of look at them as being in parallel, but also in series. So looking at this, like we talked about, you get the D side, right? You don't get that normal round shape of the left ventricle. And a couple things happen. When that RV increases in size, you distort the normal mechanism, the contractile mechanism. It's supposed to be kind of curving around the left ventricle. That's what it's supposed to do. So that's its ideal formation to contract properly. When you dilate, you distort that, so it doesn't contract appropriately. But even more so, you can see that as it balloons open, the septum deviates into the left ventricle. And as you get that deviation, your filling pressures for the left ventricle increases, and then you get decreased cardiac output from that standpoint. Which poses a problem, because we'll talk about that in a second. But before we do that, we'll talk about how they're in series. So again, if you have a decreased cardiac output in your left ventricle, that essentially means that in this preload-dependent lesion, you have decreased preload in your right ventricle. And that can also cause problems. And the problem is this last part, ischemia. So as our cardiac output increases, we increase our probability of getting cardiac ischemia. And a lot of that is because of coronary perfusion pressure. So for those of you who don't know, the coronary perfusion pressure is that difference between our aortic pressures and our right ventricular pressures, essentially. And what happens, again, when we decrease our left ventricular volume, our left ventricular pressure, we decrease our aortic pressure, and that changes that coronary perfusion pressure. It decreases it. The same thing happens when we increase our right ventricular pressure as well. That difference gets smaller, and we have decreased coronary perfusion pressure resulting in ischemia. Now, all of this is a vicious cycle, because with ischemia, we get more right ventricular failure, we get decreased cardiac output, and we get more ischemia. Again, we're in this very, very vicious cycle. So how do we offer cardiac support? You know, in the massive pulmonary embolism patient, we have a couple of goals. The first one is to decrease our afterload, or increase our afterload. Next one is to reduce our pulmonary vascular resistance, improve our contractility, and optimize our preload. Now, unlike most preload-dependent lesions, optimizing our preload is not, it has limited utility. And I'll tell you why. So, like we were talking about in the other lecture, in this case, our problem is almost essentially an obstruction, right? A mechanical obstruction. When we reflexively give 2 liters of fluid, what happens? It has nowhere to go, right? But it has to go somewhere. So it goes into the veins and it pools. It pools in the right ventricle, it pools in the right atrium, in the SVC, the IVC, it has to go somewhere. And that bows out the septum, causes more problems like we were talking about, and contributes to that vicious cycle. Now, this is particularly in the case of a massive pulmonary embolism, right? A decompensating patient. So it's different for regular PEs, different for submassive PEs. So what your goal is to optimize the preload. Take a look at the volume status. Is this patient's IVC compressing like it should be? Is it not compressing at all? And withhold giving fluids if you don't need to give it. So moving forward, the next goal is to increase afterload. And like we were talking about, our goal to increase our afterload is to increase our coronary perfusion pressure, prevent the ischemia if possible. So we have a few medications that we can give. Phenylephrine is great for increasing afterload, but not in this case, because like we discussed earlier, there's a ton of alpha-1 receptors in the pulmonary vasculature. So you increase, if you put in phenylephrine, you may increase your afterload, but you're also going to increase your pulmonary vascular resistance, which is, again, it's the problem, so you don't want to do that. Vasopressin is a great drug because there's no vasopressin receptors in the pulmonary vasculature, but it's not a titratable medication, so it's not ideal in this situation. Which leads us to norepinephrine and epinephrine, and I think either one, given the situation, is a good choice. I've used both, haven't had a problem with it, and we'll kind of talk about why epinephrine is okay, is a good drug to use. So our next goal is to improve our contractility. And dobutamine, epinephrine, and milrinone are our goals, are our medications for that. I don't typically use milrinone just because I think it's a little erratic as far as the decrease in afterload that it causes. So I kind of go with dobutamine and epinephrine. And this is where I was talking about epinephrine is a good drug depending on what you're trying to achieve. So if you have, if you start low, you can probably get a little bit of afterload, and as you increase, you'll probably get a little bit more contractility with it, and that kind of kills 2 birds with 1 stone. But if you do norepinephrine, not a bad choice, and you need contractility, add dobutamine. Either one, I think, is fine. But I think the point of this, or both those slides, is that if you know exactly how these medications work, what they do, how they do it, then you can get what you want by using those medications. Oftentimes we just kind of reflexively go to norepinephrine because that's supposedly the best drug, which in most cases it is, but having an understanding is extremely important. And lastly, we want to reduce our pulmonary vascular resistance. Now, obviously this is the goal, right? This is what we're trying to fix this. And we have a couple options here. We can use TPA, we can use ECMO, and we can use nitric oxide. Now, these are things that we can do in the emergency department. So obviously there's thrombectomy, there's ecos, and other things to do. You just have to mobilize your team if you have one to do that. But TPA, I would have a very low threshold to pull the trigger on this. Oftentimes we just kind of waffle around, should we give TPA, should we not give TPA? But in the acutely decompensating patient, giving the TPA is extremely important because even small changes in the pulmonary vascular resistance can significantly offload the right ventricle and have better functionality. ECMO is a great option as well. Some of us, I think there's a lot of emergency departments that are considering going to this ED ECMO model, having cardiothoracic surgery on call, et cetera, but that takes time. So placing the cannulas or placing an art line or a central venous catheter, you just wire transfer over it. Now, people kind of shy away from that because they don't want to mess up the vasculature and all that stuff, but I think that's a perfectly reasonable thing to do while you're waiting. And then lastly, inhaled nitric oxide. This will dilate the pulmonary vascular beds and it'll offload enough pressure in order to do that. Now, this is something that you have to be savvy with. You have to kind of consider it beforehand because it's something that respiratory therapy doesn't just have readily available, so they probably need to bring it down from the bowels of the hospital. But it's definitely something to consider when you're treating these patients. All right, so we've talked about kind of our cardiovascular goals and what we're trying to achieve. So what I want to move to next is respiratory support. And like we said again in the prior lecture is these patients have often looked unwell, right? And again, when we reflexively think, when we see an ultra-mental-sized patient that's short of breath, becoming more and more hypoxic, we almost reflexively say, let's go intubate this patient. Because if you protect their airway, then there's a lot of things that can happen. They don't vomit, they don't aspirate, that's great. We also decrease their metabolic need, et cetera, et cetera. But intubating these patients can make them going from really sick looking to really dead looking. And that's obviously something that we want to avoid. So like we did with the cardiovascular stuff, let's talk a little bit about physiology when we intubate these patients. What happens? So two things happen. We increase our intrathoracic or transmural pressure across the capillary beds, which increases our pulmonary vascular resistance. That makes sense, right? And then we also decrease our preload because we increase our intrathoracic pressure, which decreases our preload further in a preload-dependent lesion. So we're kind of in this catch-22. Right? Because the problem is that if you have this patient that's becoming more hypoxic, not ventilating appropriately, you get hypoxia and hypercapnia. And we obviously want to fix that, but if we intubate again, we have those problems that we discussed. But here's the other problem. The other problem is that if you have hypoxia and hypercapnia, you get increased pulmonary vascular resistance. And again, we're kind of down again in that vicious cycle of causing this patient to more harm than good. So if you need to intubate, I think it's perfectly fine to intubate. Just know exactly how you're going to do it, when you're going to do it, and the best way to do it. So let's talk a little bit about what you would do. And I don't have any slides after this, just because what I'm going to tell you, I think, is more personal practice, personal preference, based on physician to physician. So here's what I would do. I would read for my medication. And just show of hands, what would it be, or not show of hands, like who would choose for your sedatives first? Reach for your sedatives first. Right, so I personally would. The first medication that I would reach for would be my push-dose suppressor. So probably epinephrine. Norepinephrine takes a little bit to make. And the reason I say this is because you have a decompensating patient. If you want to intubate this patient appropriately, you want to optimize your cardiovascular physiology. You want to optimize everything as much as possible. So I push that and see. I push 1 milliliters, 2 milliliters, and see what happens. You know, how much medication does it take to increase this patient's systolic blood pressure, their systolic blood pressure and kind of improve their perfusion. Because the last thing I want to do is have this patient decompensate, and when they decompensate, I'm busy trying to fiddle around and trying to figure out exactly how much medication to give, right? And the other problem is that when you have pump failure, you're not going to be able to circulate that medication as well, right? So if you give it beforehand, you can get that medication circulating, get that cardiac function improved and into it. And after that, you can use your ketamine, your etomidate, whatever you want to sedate with, and if you need to paralyze with some sort of bully or not, whatever your drug choice is. All right, so hopefully this is helpful. Hopefully this will help you next time you guys have a massive PE patient. That's about it.